morning, everyone. I'm Purvi, one of the HPM fellows at Trinity Health, and I'm really pleased to be speaking with you today about medical marijuana or medical cannabis and its role in hospice and palliative care. As interest and access have grown, so have the clinical questions. So today, we'll look at the evidence, the risks, the legal landscape, and how we can thoughtfully integrate cannabis into comfort-focused care. Patients and families are asking about cannabis more than ever. In some settings, it's being used without clinician oversight. And as physicians, we should understand the clinical reasoning behind when and how it might help or hurt in end-of-life care. So we'll discuss the therapeutic potential, evidence limitations, and clinical pearls for safe use. All right, and I have no disclosures. Learning objectives for today will be describing the history and pharmacology of medical marijuana, identifying the clinical evidence supporting the use of cannabinoids in managing symptoms like pain, nausea, anxiety, and appetite loss in hospice patients, recognizing the challenges that healthcare providers face when integrating marijuana into a patient's palliative care regimen, navigating legal and ethical considerations, as well as applying practical strategies for introducing cannabis to appropriate patients. Thank you. So the historical use of cannabis as medicine. Cannabis has a rich history dating back thousands of years. The Chinese pharmacologist Shenong documented cannabis use around 2700 BCE for a variety of ailments, including pain and gout. Similarly, ancient Indian Ayurvedic texts describe cannabis as a treatment for epilepsy and digestive disorders. Egyptian medical texts such as the Ebers Papyrus also include cannabis preparations for inflammation and eye disease. Cannabis in Greek and Roman medicine. In classical antiquity, cannabis was used medicinally by figures like Dioscorides, who documented its analgesic and anti-inflammatory properties. Galen, a key figure in Roman medicine, used cannabis preparations for earaches and swelling. These traditions indicated an awareness of cannabis's therapeutic potential in multiple cultures. Cannabis in medieval Islamic medicine. During the medieval period, Islamic scholars like Avicenna included cannabis in medical texts for neurological disorders, including epilepsy and migraine headaches. This knowledge was preserved and later influenced European medicine during the Renaissance. So, introduction to Western medicine. Western medicine re-encountered cannabis in the 19th century through the work of William B. O'Shaughnessy, who described cannabis's effects in India. Soon after, cannabis extracts became common in Western pharmacopoeia, and it was used for pain relief, muscle spasms, and gastrointestinal symptoms. It remained popular through the early 20th century. U.S. pharmacopoeia and 20th century regulation. In the U.S., cannabis was officially listed in the pharmacopoeia from 1850 until 1942. However, beginning with the Marijuana Tax Act in 1937 and culminating in the Controlled Substances Act of 1970, cannabis was heavily regulated and classified as Schedule I, indicating no accepted medical use and high abuse potential. This federal stance severely limited clinical research for decades. California was the first state to legalize medical cannabis, passing Proposition 215 in 1996. Colorado and Washington were the first states to legalize recreational cannabis in 2012. And Michigan legalized medical marijuana in 2008 with the passage of the Michigan Compassionate Care Initiative, Proposal 1, as well as recreational marijuana got legalized in 2018 through the Michigan Regulation and Taxation of Marijuana Act. state licensed recreational cannabis sales began in December of 2019, so not too long ago. The Marijuana Tax Act and Federal Schedule 1. So the 1937 Marijuana Tax Act imposed heavy taxes and regulations, which led to near prohibition. Later, the 1970 Controlled Substances Act classified cannabis as Schedule 1 alongside heroin and LSD. This greatly limited scientific research and clinical prescribing despite growing evidence in state level legislation. This conflict continues to challenge physicians. We're now going to talk about the endocannabinoid system, also known as the ECS. So the ECS is a complex cell signaling system discovered in the early 1990s. It plays a vital role in maintaining internal balance or homeostasis. The system includes cannabinoid receptors, natural cannabinoids produced by the body, as well as enzymes that synthesize or break down these molecules. The system is key to understanding how cannabis exerts therapeutic effects. So the receptors that we'll talk about are CB1 and CB2. The endogenous cannabinoids are the anandamide M2AG, and the enzymes are FAAH and MAGL. So the CB1 and CB2 receptors. The CB1 receptors are highly concentrated in the central nervous system and mediate many of the psychoactive effects of THC, including pain modulation and mood effects. CB2 receptors are mainly found in the immune system and help regulate inflammation and immune responses, which is especially relevant for inflammatory symptoms and neuropathic pain. Endogenous cannabinoids. Our bodies naturally produce cannabinoids such as anandamide and 2-AG. These act as messengers binding to cannabinoid receptors to regulate pain, appetite, mood, and immune function. Unlike typical neurotransmitters, they are synthesized only when needed and they act locally. So this allows for precise regulation. ECS role in pain and inflammation. The ECS influences how the nervous system processes pain signals, both nociceptive and neuropathic pain. It also modulates inflammatory responses by reducing cytokine release. This makes it a promising target for managing difficult symptoms that are often seen in our hospice and palliative care patients. So ECS's role in appetite, mood, and nausea. Activation of CB1 receptors in the brain stimulates appetite and food intake. This can help counteract cachexia and terminal illness. The ECS also plays a role in regulating mood and anxiety, often disturbed in advanced illnesses. Additionally, it modulates nausea and vomiting centers, providing antiemetic effects, and this is usually useful in our chemotherapy-induced nausea patients. THC is the primary psychoactive cannabinoid in cannabis, and it is responsible for the high. It activates both CB1 and CB2 receptors, producing analgesic and antiemetic effects, as well as increasing appetite. Side effects can include dizziness, anxiety, and sedation, and they're all dose dependent and are they can really limit our use, especially in frail patients. CBD is the non-psychoactive cannabinoid. It's non-intoxicating and works mainly by modulating ECS receptors indirectly and influencing other signaling systems. It has anti-inflammatory, anxiolytic, and anticonvulsant properties, making it useful in symptom management with fewer side effects related to cognition or sedation. CBD can also mitigate some of the adverse effects of THC. Besides THC and CBD, cannabis contains many other cannabinoids and plant compounds. like terpenes, which may modulate effects and side effects. The entourage effect hypothesizes that these components work synergistically to enhance therapeutic benefits, though more research is needed to clarify their roles. This can be really seen, especially with the entourage effect, in that we do have some FDA drugs that do contain cannabinoid compounds, which we'll talk about a little later. But with this synergy that's needed amongst all the compounds that are present in the actual cannabis sativa plant, you'll see that oftentimes you won't have the same effects that patients have using the plant with some of our FDA approved drugs that just have a specific compound that they're using. Oh, I think we froze a little. There we go. Okay. Cannabis product types and routes of administration. So cannabis is available in various forms, each with different pharmacokinetics and clinical applications. Inhalation provides rapid symptom relief, but may pose respiratory risks. Oral preparations have a longer duration, but a slower onset. Sublingual and topical options offer alternatives for patients who cannot or prefer not to inhale. So choosing the right product and route is critical to balancing efficacy and safety. So with the flower, that can be smokable or vaporized. Based on what I was seeing, vaporized is just more preferred because when you're smoking, it's going to be at a higher temperature and you get a lot of those other substances that can be produced like carbon monoxide. Oils, tinctures, and concentrates are another product, edibles and capsules, topicals and suppositories, and then we kind of touched base on the routes already.
Can I ask a question? I had a patient last week and we were, she's cachectic and whatnot. We were talking about different options. So we were talking about this and she said, well, I just can't stand the smell. Yeah. And so I said, well, have you considered edibles or things like that? And she said that she has tried those, but they have, to her, a similar smell, taste, etc. Mm-hmm. I'm curious if anyone else has had experience like that. I always thought, I'm just curious, is that for all edibles or was that just one person's experience or any idea?
Just kind of based on what I have experienced in the ED, obviously the smell is strong for, the smokable one, but I don't think I've noticed that the taste is particularly an effect when people are using it in edible form.
I wonder if she just hasn't used or experimented with enough edibles, maybe whatever she got, if there's something different. Like I thought, like, do gummies taste? I mean, I know the smell when I'm at a concert, and that's what she was describing, tasting, I think.
Had a couple of patients say when they go to these dispensaries that you can actually have these products flavored too.
Okay, like, so there are a lot of options. Okay.
And yeah, there's different ways that you can also use it. Like some people will like put it in brownies and somehow that takes away like the taste.
That's what I was thinking.
But for some people it might be sensitive. Yeah, I didn't look into that specific thing, but yeah, that can definitely be like another thing that we need to think about in terms of form.
Yeah.
That could work for patients.
Yeah. All right.
So onset and duration of effects by route. Understanding the onset and duration is crucial for symptom targeting. Inhalation will give you that rapid relief that's ideal for breakthrough symptoms, but it might irritate your lungs. Oral products will have a delayed onset and longer duration, which is suitable for baseline symptom control. Sublingual preparations will bypass that first pass metabolism, so you'll have a quicker effect than orals. And then topicals mainly provide localized relief with minimal systemic absorption. I did notice when I was kind of preparing this chart over here that different research studies and articles that are out there have different timings with the onset and peak effects. So I kind of just took like an average and put it together here, just based on everything that's kind of out there. It seems like there hasn't really been a lot of research on every route. So this is really just what's out there right now. And there's a couple of other charts that I'll have and a little bit here that shows similar times as well. So this one just kind of, this slide talks about the pros and cons of each of the different routes. We already talked about the timing, but for inhalation, one of the disadvantages is that respiratory irritation as well as that societal stigma. The oral route is more discreet, but it has variable absorption and delayed onset. The sublingual route is great in that there's no lung risks, but the taste is a disadvantage and there's not as many formulations. And then the advantage of topical is that it has localized treatment, but the disadvantage is limited systemic effect, which might be helpful for some people who are just wanting specific localized treatment. But again, here's just another chart showing your administrative routes and kind of comparing that. So yeah, I mean, it kind of touches base on everything that we've already talked about. The additional thing here is you get some of the bioavailability in your inhalation and ingestional routes. So, indications for medical cannabis and palliative care. Medical cannabis has been studied and used for a variety of symptoms encountered in palliative care. Its potential to manage pain, nausea, appetite loss, anxiety, and sleep disturbances makes it a valuable option when conventional therapies are insufficient or not tolerated. So these are just some of those indications that I found. Cannabis for pain management. Cannabis appears more effective in neuropathic pain syndromes, which are often resistant to opioids or NSAIDs. Meta-analyses demonstrates modest improvements in pain scores. Importantly, cannabis may allow for opioid dose reduction, which can improve safety and quality of life in palliative patients. Cannabis and opioid-sparing effects. Several studies indicate that cannabis can work synergistically with opioids, enabling lower opioid doses while maintaining pain control. This is particularly relevant in hospice care, where reducing opioid side effects like constipation and sedation can significantly improve comfort. However, we do need to carefully monitor these patients because of the potential CNS additive depressing effects. Cannabis for nausea and vomiting. Cannabinoids have been used for decades to treat nausea and vomiting, especially in chemotherapy patients. Synthetic THC analogs like dronabinol and nabilone are FDA approved for this indication. And cannabis can be an option for refractory nausea or when standard antiemetics are ineffective or poorly tolerated. Appetite stimulation and cachexia. Cannabis is well known for increasing appetite, often called the munchies. THC activates your brain centers that control hunger. However, clinical trials show mixed results on actual weight gain. Cannabis can be helpful to improve oral intake, but it should be combined with nutritional interventions for the best outcomes. Cannabis for anxiety and mood disorders. CBD does have promising anxiolytic and antidepressant effects without psychoactive effects, so it makes it a safer choice for anxiety. THC's effects on anxiety are dose dependent as well as individual specific. So it can worsen anxiety in some patients. So you do want to use caution when you're using it in patients that have a history of psychosis or mood disorders. Sleep and insomnia. Cannabis can help patients fall asleep faster and increase total sleep time, primarily due to THC's sedative properties. However, tolerance may develop and chronic use can sometimes disrupt the sleep architecture. CBD's role in improving REM sleep and reducing nightmares is being explored, especially in our PTSD population. Cannabis for agitation and delirium. So agitation and delirium are common in advanced illness and challenging to treat. Some early studies suggest that CBD may reduce agitation without the sedative effects, but more research is needed. THC can worsen agitation or cause sedation, so use for THC should be cautious and only after other treatments have failed. Safety profile of medical cannabis. Medical cannabis is generally safe, but side effects like dry mouth, dizziness, sedation can affect quality of life. Cognitive effects and increased fall risks are important considerations in our older or frail patients. We do lack robust long-term safety data in this population, so monitoring is key. Contraindications and cautions. Again, patients with active psychosis should not use cannabis due to risk of exacerbation. Cardiovascular conditions pose risks given THC's effects on heart rate and blood pressure. Some of those effects are in the short term, patients can get tachycardic and hypertensive. And in the long-term setting, they can start to have hypotension, more so orthostatic hypotension. Cannabis isn't recommended during pregnancy or breastfeeding, and caution is warranted in patients that have a history of substance use. Drug interactions. So cannabinoids are metabolized in the body primarily by the liver through the cytochrome P450 system. THC and its metabolites are excreted through urine and feces. A significant portion, 80 to 90%, is excreted within 5 days, primarily as hydroxylated and carboxylated metabolites. Since cannabinoids are metabolized in the body primarily by the liver through the cytochrome P450 system, that also processes many other medications, this can lead to interactions, particularly with blood thinners, sedatives, and antidepressants. The risk of additive CNS depression requires cautious dosing and close monitoring, especially in polypharmacy, which is common in the elderly population, which is a population which is also usually served in palliative and hospice care. Dosing principles: start low and go slow. This is mostly because of the interpatient variability and sensitivity, so starting low and titrating slowly is essential. Many clinicians prefer starting with CBD-rich or balanced CBD-THC products to minimize the psychoactive effects that you can get with THC. You always want to monitor dosing to the patient's symptoms and side effect profile. Although there is no standardized dosing guidelines yet, I did find some protocols for routine, conservative, and rapid administration that we'll go through in the next few slides. So this is the routine protocol for medical cannabis dosing and administration. You do want to start with a CBD predominant cannabinoid. The starting CBD dose would be 5 milligrams twice daily. And for titration, you can increase that CBD predominant cannabinoid 10 milligrams a day, every 2 to 3 days. So now, when do you add that THC in? If they're not reaching the treatment goals when the CBD predominant dose is greater than or equal to 40 milligrams per day, then you want to start that THC dose. And you'd want to start it at 2.5 milligrams a day. And for titration, increase it by 2.5 milligrams every 2 to 7 days until the goals are met or a maximum dose of 40 milligrams per day of the THC is reached. The conservative protocol for medical cannabis dosing and administration is more so for our elderly and frail patients. So for this one, the starting CBD dose would be 5 milligrams once or twice daily instead of the 10 milligrams. You would titrate this 5 to 10 milligrams a day every 2 to 3 days. And then you can add the THC again when the CBD predominant dose is greater than or equal to 40 milligrams per day. And then you would start the THC dose at 1 milligram a day compared to the 2.5 we were talking about before. And for titration, we would increase it by 1 milligram every 7 days until the treatment goals are met, or you get a maximum dose of 40 milligrams per day of the THC. There is also a rapid protocol for medical cannabis dosing and administration. You would want to start for this one with a balanced THC to CBD cannabinoid. The starting dose will be 2.5 to 5 milligrams of each of the cannabinoids once or twice daily, and then increase it by 2.5 to 5 milligrams every 2 to 3 days for each of the cannabinoids once or twice daily until your goals are met, or you get a maximum dose of 40 milligrams per day. Monitoring and follow-up. Regular follow-up is critical to ensure efficacy and safety. You want to use symptom scales to quantify improvement and screen for side effects, especially cognitive changes or sedation. You want to adjust the treatment plan accordingly and discontinue the cannabis if adverse effects outweigh your benefits. Documentation and legal considerations. Clear documentation of cannabis use is essential both for clinical care and legal protection. So we must be familiar with the state-specific laws and institutional policies, especially since federal law conflicts remain. It's important to inform patients about potential consequences, such as effects on employment or insurance coverage as well. Ethical considerations. Ethical practice requires honoring patients' choices while providing honest counseling about benefits and risks. Cannabis contains or carries a stigma as well as misinformation, so clear communication is necessary. Shared decision-making can also empower patients as well as support holistic care. So this is just one of the case reports that I found in which cannabis alleviated neuropathic pain and reversed weight loss in a diabetic neuropathic cachexic patient who was also a previous heroin abuser. So the patient was a male with severe diabetic neuropathic pain and cachexia. Prior to the study, he was using pregabalin 75 milligrams twice a day and duloxetine 60 milligrams BID as well as 30 milligrams once a day. This current regimen had proved inefficient. He was also using an opioid tramadol which caused him intolerable dizziness and instability. 4 months after he started the medical cannabis, he reported improved appetite. He regained 10 kilograms of body weight and was enjoying a peaceful night's sleep. He had improved strength in his legs and decreased pain. His visual analog pain scale went from 6 to 7 out of 10 in severity to 2 out of 10 in severity. His daily cannabis dose did vary between 3 and 5 drops of oil extract, depending on how much he was suffering. When asked about the risk of abuse, he expressed no cravings to increase the dose and did not feel stressed when he was away from home. He could tolerate some increase in pain until he arrived back home and could start using again. But he only had to take 1 more drop more than usual when this would happen. He found that a 20 cc vial of the THC 10 to CBD 10 oil extract was sufficient for him for a month. This is another case report that I found of treatment-resistant agitation and dementia with Lewy bodies, in which they used medical marijuana as an alternative to antipsychotics. In this case, the patient was an 85-year-old male with Lewy body dementia with symptoms of severe agitation, aggression, and unresponsiveness to antipsychotics for his aggression. They did use a THC tincture, but the dose was not specified. Although it wasn't specified here, I mean, the best practice is to start low and go slow. So based on other studies, it seemed like beginning with 1 to 2.5 milligrams of THC, assessing response, and then titrating for those other guidelines we talked about before would be ideal. There were some other studies that I had pulled, and one had shown an average of 7 milligrams of THC to 14 milligrams of CBD that was used daily over 2 weeks. So that's somewhere that they ended up landing in another study. Another case report was this one that I have right here, in which they showed medical marijuana being used in pediatric palliative care. So in this one, there were 3 patients that they talked about in this case report. So we'll kind of go through each of those 3 patients in detail in the next few slides here. So in case 1, cancer symptom burden and polypharmacy, this patient was an 11-year-old male with relapsed rhabdomyosarcoma. He was heavily medicated for symptom control with 4 daily agents, Zobran, zipriheptadine, gabapentin, and Tylenol, each with their own side effects. After introducing a 1-to-1 cannabis tincture, he achieved better symptom management while tapering or discontinuing all 4 prior medications. Notably, the gabapentin was weaned and his mood and appetite improved. This case underscores medical cannabis's value in reducing medication burden while improving function and emotional well-being. Case 2 was spastic quadriplegia and pain management. The patient was a 15-year-old female with hypoxic brain injury and spastic quadriplegia. 15 months after starting medical marijuana, she had briefly been able to discontinue her gabapentin. So prior to the cannabis, she was on gabapentin, max weight-based dose of baclofen, oxycodone, which she used post-op following a spinal surgery, botulism toxin injections, as well as nerve blocks. So 15 months after starting, she was able to briefly discontinue the gabapentin. But she did eventually have to require restarting it due to the return of her neuropathic pain when she was doing increased levels of physical and occupational therapy. They did pause this while she was recovering from the spinal fusion, but then restarted it. While she has continued to report benefits from medical cannabis following 2 years of use, her spasticity still contributed to pain and limited her mobility. So she actually might end up pursuing baclofen pump placement, but it was helpful for her in terms of at least the spastic components. She was at a point where she couldn't even close her mouth. And once starting with, with cannabis, she was able to make more facial movements, and her family had noted an improvement overall. So case 3, this is about an 11-year-old male with Lennox-Gastaut syndrome, a CHD2G mutation with Dravet syndrome-like features, and autism spectrum disorder. In this case, the patient was on 5 anti-epileptic drugs, CBD, a ketogenic diet, as well as a vagus nerve stimulator, and had a corpus callosum. He was having, despite all of that, more than 150 seizures a day. After he initiated a THC inclusive formula and titrated it carefully, he saw a profound drop in his seizure frequency. And as cannabis became his mainstay, other drugs were able to be minimized. His mother described the shift in behavior and cognition as life-changing. And so I found this to be a powerful example of cannabis complementing and potentially supplanting traditional polypharmacy. 1 year later, he was taking 3 anti-epileptics and had transitioned off the ketogenic diet. As a temporary ketogenic diet can reduce seizures, medical marijuana is also unlikely to have been the sole contributor to his improvement, but it definitely seems like there was some improvement in terms of mood and aggression, as well as the ability to have fewer anti-epileptics on board. These are just some resources that I found for physicians to use if interested in trying to learn a little bit more about medical cannabis. Addressing stigma and misconceptions. So stigma does remain a barrier to acceptance. Medical cannabis is a carefully managed therapeutic option that's distinct from recreational use, and it's important to educate patients and families about the distinction between medical and recreational use. Legal landscape overview. So as we discuss medical cannabis in clinical practice, it's critical to understand the complex and evolving legal environment that shapes what we can and cannot do as clinicians. As of 2024, 38 US states and the District of Columbia and 3 territories have legalized some form of medical cannabis. However, cannabis remains a Schedule I drug federally, meaning it's classified as having no accepted medical use and a high potential for abuse. This puts us in a challenging position legally and ethically. The federal classification hinders research, especially in pediatrics, since institutions receiving federal funding are often reluctant to sponsor cannabis studies or even allow its use on premises. Hospitals also vary in policy. Some prohibit any cannabis use on site, even when it's legally recommended. But I did find this one study in which Akron Children's Hospital has protocols allowing caregiver administered cannabis. So patients are taking this in the outpatient setting. Physicians give recommendations.
I'm happy to see you here. You too, as well.
Thank you.
You're welcome.
Please mute everybody. Someone's got a hot mic.
Nice.
So so in that case, family members were able to administer that cannabis to the patients.
She didn't respond to Garrett. She didn't respond to me. You saw mine come through last night?
Okay.
Yep. Oh, I think it worked. So we must remain up to date on our state's qualifying conditions, certification procedures, and institutional policies, especially when we're recommending cannabis for pediatric or vulnerable patients. In many states, conditions like cancer, seizures, and terminal illnesses are now qualifying indications. Selecting cannabis products. Product selection is tailored to individual needs, and balanced THC to CBD products often reduce the side effects. When possible, you want to use standardized, lab-tested products for dose consistency. Patient history and preferences do play a role in choosing formulations. So kind of like you were talking about earlier with your patient who didn't like the smell of marijuana, seeing what's worked for them in the past can influence what you use for patients going forward. Educating patients and caregivers. So education is critical to treatment. Patients and caregivers should understand how to use products safely, recognize the adverse effects, and know how long it may take to see benefit. Safe storage is also important to prevent accidental ingestion. So now moving on to some of our FDA-approved cannabis-derived drugs. There are 4 that I was able to find, the Epidiolex, Marinol, and Syndros, as well as Sesamet. So we'll go into more detail about these in the next few slides here. The Epidiolex was the first FDA-approved medication derived from cannabis. It contains CBD and is approved for treating seizures associated with LGS and Dravet syndrome. Formulation, it is an oral solution. It contains 100 milligrams of CBD per ml. The typical starting dose is 2.5 mg per kg twice daily, and it can be increased gradually to a max of 10 milligrams to 12.5 milligrams per kilogram twice daily, depending on what's being treated. And then listed are the common side effects of sleepiness, decreased appetite, diarrhea, and fatigue. Marinol is another one of our FDA-approved drugs, and it contains dronabinol, which is a synthetic form of THC. It's approved to treat nausea and vomiting that's caused by chemotherapy, as well as to stimulate appetite in patients who have AIDS. It does come in capsule form in 2.5, 5, and 10 milligram doses. And most of the patients respond to 2.5 to 5 milligrams twice daily or 1 hour before meals. It has similar side effects to the other one, but you do get some changes in thinking as well as feeling high, as this is more of that THC side of cannabis. Syndrose also contains dronabinol, which is that synthetic form of THC. This is the first and only FDA-approved liquid formulation of dronabinol. So this one comes in a 5 milligram per ml concentration. And the recommended standard or starting dose for chemotherapy-associated nausea and vomiting is 4.2 milligrams with your body surface area, administered 1 to 3 hours prior to chemotherapy, and then every 2 to 4 hours after chemotherapy for a total of 4 to 6 doses per day. The recommended dose to stimulate appetite in patients with AIDS is 2.1 milligrams oral twice daily, 1 hour before lunch and dinner. And then it has similar side effects to Marinol. Sesamet contains nabilone, which is a synthetic substance similar to THC. It's also used to treat chemotherapy-induced nausea and vomiting. This one comes in capsule form at 0.25, 0.5, and 1 milligram doses. The usual dose will be 1 to 2 milligrams BID for a max dose of 6 milligrams per day, divided into 3 doses daily. And again, similar side effects to the other two substances, or the other two drugs that have substances similar to THC. Cannabis use in special populations. So certain populations do require extra caution. The elderly are more susceptible to side effects and cognitive impairment. They're also more of a fall risk. Use in pediatric palliative medicine is very limited and experimental. Patients with psychiatric histories do need close observation for potential worsening of symptoms. So you do want to continue to monitor them. Emerging research and future directions. So research continues to expand our understanding and improve cannabis therapies. Future directions include precision medicine tailoring cannabis to individual biology, development of new cannabinoids with improved efficacy and safety, and better integration with standard palliative care. I did see some interesting new research that I came across while preparing for this presentation, one of which is the life end benefits of cannabinoidal and tetrahydrocannabinoidal Libby study. It's a multi-center randomized double-blind placebo-controlled phase 2 study, which investigates the effectiveness of an oral combination of THC and CBD in reducing agitation in hospice care eligible patients who have dementia. They will be studying approximately 150 hospice care eligible patients aged 40 and older with agitation and dementia. Participants are randomized to receive either the active study drug, which is a THC CBD combination, or a placebo in the form of a digestible oil twice daily. They are recruiting from around 15 clinical trial sites in the US. There's also the CAP-CARS trial, which is a clinical trial investigating the effectiveness of cannabis oils for managing cancer-related symptoms. This study aims to determine which combination of cannabis extracts, whether it's high THC, low CBD, low THC, high CBD, or equal amounts of THC and CBD, which one of those is the most effective for individual patients compared to a placebo. This will be a randomized double-blind N of 1 trial. Participants will receive those different oil-based extracts over a 16-day period that can be repeated. And then there's also a few other trials that are being done in Australia. The results from these studies in the next couple of years can really help us get more information about the role of cannabis in the medical field in general. Cannabis use at the end of life. So at the end of life, the focus shifts to comfort, and cannabis can help manage multiple distressing symptoms such as pain, agitation, and insomnia with favorable side effects profiles compared to polypharmacy. Even if evidence is limited, it can be justified when you're aligning it with patients' goals and values. Next slide. Cannabis use in faith and cultural contexts. Cannabis use can intersect with patients' religious or cultural beliefs. It's essential to approach these conversations with sensitivity and openness. Understanding cultural context supports holistic, respectful care, especially in the end-of-life setting. Cannabinoid versus other adjuncts. So for neuropathic pain, you could use THC or CBD. Traditionally, Gabapentin and amitriptyline are some of the drugs that we do use. Nausea, traditionally Zofran, metoclopramide. The cannabis options would be THC and Navalone. Anxiety, could use CBD, and appetite, we could use THC. Barriers to clinical use. So despite increasing legislation, many clinicians still feel unprepared to recommend cannabis due to a lack of training and ambiguous regulations and research. Access to consistent, high-quality products is also a big concern. So these barriers must first be addressed in order to start utilizing cannabis in the medical field. Medical cannabis education is also still lacking in formal curricula. We often need to seek out continuing education independently. As the field continues to grow, I think institutions should support protocols and mentorship to improve clinician confidence and competence in using medical cannabis. Documenting the rationale and course of cannabis treatments can also protect you legally and help to guide care. So consent forms and regular follow-up notes are essential. Unfortunately, insurance rarely covers cannabis-related services, so patients may face out-of-pocket costs. And using medical cannabis in palliative care is not just the physician's responsibility, but since we already are a big interdisciplinary team, utilizing other members of the team would also be very good in terms of nurses with monitoring effects and patient education, pharmacists helping with drug interactions and doses, social workers working with stigma access, as well as caregiver support, and chaplains helping with the spiritual perspectives on use. So summary and take-home points. Medical cannabis can improve quality of life by managing symptoms like pain, nausea, and anxiety. However, knowledge of its mechanisms and careful dosing is still being worked on through research and evolving laws. So at this point, kind of just talking with patients and shared decision-making, seeing where they are at, and seeing where the research kind of takes us. And then those are my references. Yay. All right.
Thank you so much.
Thank
This is
you.
great. Yeah. Screen sharing and open it up for questions.
We'll hear through that speaker. There we go. Okay. I'm curious, as you were looking through like the references and research, I would imagine that starting in the, when medicinal use started coming online, being legalized in limited states and moving, has research, is there like a spike or a growth pattern in just research that we're seeing? Right, prior to the 1990s, it was pretty scant to close to zero.
Yeah.
I guess similar to like with psychedelics and things like that. But
Yeah. I mean, definitely just kind of seeing over the years, we went from having just a couple of states that were legalizing marijuana and then to where we are now. There has definitely been an increase in the amount of research that I've seen, like even from just a couple of years ago when I first started like seeing what medical cannabis is, when patients brought it up, there wasn't as much research. And then looking to now where they're actually doing more research on it and there's more dosing guidelines. So back in the day, the research that was shown, a lot of it was patients using different types of, cannabis, whether it was smoked or vaped or edibles. And there was no standard to those research. It was really just, hey, this is what you're using. Let's see what happens. And now they're coming up with research studies in which there is the cannabinoid that you're using. Is it going to be just CBD? Is it going to be THC? And what form are we using? And then studying it from there. So that's a big difference that I've seen, as well as just more research in general and even investigating what it can offer.
Because hopefully you'll see it continued almost like a snowball effect.
Yeah.
Right. And the point about, the federal, it's still not legalized at a federal level and thus federal funding for research, right? So where is the research being done? Is it, I'm imagining in some states there would be statewide funding, and it's just a lot of it. And when you think about some of the other medications we prescribe regularly, the side effect profile here is pretty tame. So,
Mhm.
so thank you for doing this.
Yeah. I mean, I just had a lot of patients kind of ask about like,
Mhm.
I don't know, especially in the ED even, like, I feel like when I was seeing patients throughout residency, when asking about, what they're using, patients were more so saying that they were smoking marijuana than smoking cigarettes. And so I just feel like it's just going to become this more prominent thing. And we just, I mean, I personally at least didn't know much about it. And so I just wanted to see what the use would be in.
I'd be curious what people on the call would say, or your experience, because I still feel I've been doing this for, 20 years.
Mhm.
I still feel like I'm having an off the record conversation.
When patients bring it up.
And when they
Yeah.
bring it up,
Yes.
and I'm speaking mostly from anecdotal experiences. Now, oftentimes I can share other patient experiences, but
Right, and but patients have access to like dose, what's the dose and how is that regulated? It's like supplements.
Mhm.
You know, what's the guarantee that what the label says is what's actually in the
Mhm.
product that they're ingesting?
Mhm.
You know, and like a lot of patients will bring up like, oh, well, I have gummies and I just take a half of it. I don't know what that means.
Yeah.
What do you have?
And unfortunately, my advice has often been when you go to the dispensary, tell them what symptoms you have and see what product they recommend.
yeah. And hope that,
It feels like horrible medical advice.
again, variation, right?
Everything's counter, right? Yeah.
I would bet there's some people incredibly knowledgeable,
Mhm. Yeah.
almost like a pharmacist.
Mhm.
In fact, I wonder if in time, right, maybe as your careers evolve, there'll be, that'll be an accreditation at a
Yeah.
pharmacy level.
Like a cannabis sommelier.
Yeah, right.
I like that. They're called bud
It has a hand up.
Yeah, hi. Actually, this is Linda McBride, and I do mostly palliative for outpatient cancer care. And you guys were just finishing touching on what my question was going to be about, and that is it common for the dispensaries to uh, have labels that will tell the patients what they're using? Because I do have a lot of my cancer patients who tell me they're using at home in one form or another, and I have not been sure whether to ask them to, bring it in. Let me take a look at the label. Let's see if we can fine tune what you're already doing, because they do have variable results and they're not able to really qualify or quantify to me whether it's working for them or not. Definitely they will say sometimes it's working. So, yeah, thank you so much for some of the dosing information that you're giving, because I would like to fine tune this a little bit for my patients as well as I can. And then the follow-up question would be, are there legal implications? Like if we were to like go visit a dispensary and see what they have? I mean,
I was just thinking that.
We should take a field trip.
Field trip to see and talk to the people there and see what kind of products patients are. I mean, you think our patients walking into these dispensaries with the same level of ignorance that we've got
Mhm.
and a
Yeah.
wall of different products.
I would bet
So
their level of sophistication is far higher than most of ours.
yeah.
you're right. But maybe a field trip. I mean,
Yeah.
depending on the state that you're in. I mean, if there's a dispensary, why not? Go to your local Sky Mint and see what they got. See what's available.
See how they label
I
everything.
think that's
now.
actually a really good idea, because I drive past them all the time.
Same.
Yeah.
And it's probably partially just my own curiosity as well as a professional curiosity.
Uh-huh.
But if we did it as a group, because I still feel, you mentioned stigma so many times through here.
Yeah.
And again, I think that really speaks to, there's a lot of factors at play for that. But again, I've seen so many patients like cachectic, they come back a few weeks, month or so later, and they've put on some weight and their quality of life has improved and prognosis is unchanged.
Mhm.
But a lot of factors that address their suffering have improved. So.
Yes. Or
Yeah.
to reduce other pill burden.
Yes, yeah, the
You know, I love a medication that can pull double duty, on
Yeah.
symptoms. And I'm really curious to see what kind of research comes out as far as treating agitation
Yes.
with a medication that's not an antipsychotic, because, I mean, again, it kind of goes to stigma. You're treating one for another, you know, the starting me on an antipsychotic versus starting around THC or CBD. But, you know, if we look at side effects as well, you know, I think that's something interesting and
Yeah.
hopefully research to look forward to in the future
Mhm.
as this becomes destigmatized. You had mentioned, you know, as far as, you know, side effects and abuse potential. I mean, we've got stuff that we're prescribing on the daily that's
Yeah.
Right.
got a higher side effect profile and abuse potential. So
Yeah.
it just, I think, will come down to, you know, regulation and what's the formulation and how is that being delivered to patients? Having confidence in that.
Yeah, I mean, one of the big reasons also like why I wanted to do this lecture was, you know, patients are already using marijuana, right?
Mhm.
And they're finding benefits with it. Are they really going to listen to us if we say, hey, don't use this medication, like don't use cannabis, like don't do what you're doing that's working for you and try these other meds? Like if we could try and just see, you know, what even is out there and help best support them. At this point, we can't prescribe the actual like full cannabis, but you know, they're in certain states you're able to give recommendations, and like even at Akron Children's Hospital, you're able to give those recommendations and family members can administer the medication even in a hospital setting. So just wanted to see, you know, what all we can learn from that.
I think with our patient population, right, I mean, high rates of mortality, high rates of symptom burden, high rates of suffering. You know, my take has always been the higher, like someone comes in with a stage 1 breast cancer and I can give them a greater than 95% 5-year survival benefit if we stick to the protocol. Let's stick as close to this protocol as we can. Someone comes in with a metastatic lung cancer, 6-month survivorship is less than 10%. I think our job as clinicians is to be skeptical enough to keep them safe, right? If you see something that's highly, you know, and you'll see it, right? They brought something in and there was this study, it was done somewhere else, it wasn't accredited and blah, 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 for $19.99, and that could be $19 or $19,000. You know, let's be skeptical enough to keep them safe, right? But then open-minded enough. My father-in-law taught me this phrase, when I feel it's not grossly gonna harm the patient, feel free to give it a try. And if it works for you, maybe it'll help someone else. You know, so share your experience with me. So try to, as you're comfortable, give them the agency to do that.
Well, thank you. Great presentation.
Thank you, everyone.
Yeah.
We ready?